Bismillahirrahmanirrahim. Alhamdulillahi Rabbil Alameen. Now this is the tutorial for the house officer which are working in the wards, and we are talking about these complications of the cirrhosis of the liver. And before this, 5 session has been done. This is the 6th one. And this complication is known as hepatorenal syndrome, a misnomer, and it is confused by many of the students and as well as clinicians. There is a hepatorenal syndrome. Or you can say that the effects of the hepatic deterioration which will affect the renal functions. I am Professor S. Ali Azhar. I am the honorary professor of medicine globally online without any fame and economics, just for the sake of your clearance of the problem. Hepatorenal syndrome. And please do not mix with the other condition which I have told you when I was discussing the nephrology, and that is what there is the acute renal failure, acute or chronic renal failure, uremia, the glomerulonephritis, etc. Do not mix with this. In those all conditions, there is some structural damage should be done within the renal parenchyma. In this condition, the renal parenchyma, which function unit is nephron, is not structurally or organically damaged. It is only the functional capability of the nephron is affected. And there are many theories behind it. No single theory was accepted by one expert or another expert. It is very true that this occurs when there is severe deterioration or hepatic dysfunction. Yes, but what is the behind the pathophysiology, exact pathophysiology? Don't know exactly. Probably they said there's some neurohormonal substances that are acting on the renal system and they malfunctioning the renal functions, and the patient will be affected with the syndrome, that is the progressive renal failure. Type 1 rapidly progressive, type 2 is slowly progressive. And there is a volume depletion secondary to diuresis. Secondary to the diuretics, there is a history of diuretics because diuretics have already been given for the control of the ascites of portal hypertension. Or there will be history of IV vasoconstrictors or to control it, or there will be history of a liver transplantation in the end, of course. This is a summary which is given in front of you. This is the introduction of this syndrome, that is a life-threatening medical condition that consists of rapid deterioration. It is dramatic deterioration, rapid deterioration in the kidney function in individuals, associated with the cirrhosis or fulminant liver failure. Both conditions can cause this. Now, this is usually fatal unless a liver transplant is performed. But if you do the bridge type of a treatment, that is the shunt percutaneous or a transjugular intrahepatic shunt, it will worsen the condition, because the patient will go very, very quickly into the hepatic encephalopathy. Therefore, the liver transplantation is needed very, very quickly, rather than you have to wait for many, many months. Although various treatments such as dialysis can prevent advancement of the condition, because there is a metabolic derangement, temporary dialysis will improve, we can say prevent the advancement. But the essential of diagnosis, remember these tetrad. There is a worsening azotemia. Azotemia means there is a biochemistry, renal biochemistry is deranged. Not, it is a clinical condition. It is a pathological terminology. Worsening azotemia, creatinine raised, the urea is raised, or other functions of the kidney will be worsened. This is called azotemia, but not clinically affected. Secondly, the hyponatremia. Thirdly, progressive oliguria. I mean, the urine is, the pass is less than 500 ml per 24 hours. And associated hypotension, not explainable with the other conditions. Because the cardiac function is normal, the respiratory system is normal, for example, and you have not done the large volume paracentesis, in spite of it there is hypertension. There are 4 conditions should be there to diagnose this condition. Remember, the kidney is normal, so much so that it can be transplanted, according to the Professor Adibul Hasan Rizvi, that the kidneys can be taken for the transplantation. He said that. Etiology, that is repeated renal syndrome, usually affect individuals with cirrhosis and elevated pressures in the portal vein, termed portal hypertension, while the hepatorenal syndrome may develop in any type of cirrhosis. It may be pre-cirrhosis, it may be cirrhosis, it may be compensated, it may be decompensated cirrhosis. It is the most common individual with the alcoholic type of cirrhosis, particularly if there is concomitant alcoholic hepatitis. The more risky condition for this HRS is alcoholic hepatitis leading, or it is comorbid with alcoholic cirrhosis, and identifiable on the liver biopsies. Now, this HRS can also occur in individuals without cirrhosis, but with acute onset of the liver failure, that is called acute fulminant liver failure or acute fulminant hepatitis. Now, certain precipitants of the syndrome have been identified in the vulnerable individuals with cirrhosis or fulminant liver failure. These include the bacterial infections associated with the bacterial infection, acute alcoholic hepatitis, bleeding in the upper GI tract, or associated with the spontaneous bacterial peritonitis, which is the infection of the hepatic fluid, the most common precipitant of the HRS. Among them, most important one is the alcoholic hepatitis leading to alcoholic cirrhosis. So this syndrome can sometimes be triggered by the treatment for the complications of the liver disease. The iatrogenic precipitants of this syndrome include the aggressive use of diuretics. You are using diuretics, of course, for the increased output of the urine, or the removal of the large volumes of the hepatic fluid by the paracentesis. Large volume paracentesis will definitely accentuate this condition without compensating the fluid losses by the IV replacement. You are doing in your ward without replacement. You should not do the large volume paracentesis without intravenous replacement. And this is the message given. The classification of this syndrome is that that this syndrome, which is associated, common type of the kidney failure, is a failure of functions and associated with the cirrhosis of the liver or pre-cirrhosis of the liver or the permanent hepatic failure. The classification of the syndromes actually divide into two, type 1 and type 2, and both occur in individual with cirrhosis or permanent liver failure. In both categories, the deterioration in the kidney function is quantified either by the elevation in the creatinine level in the blood or by the GFR, decreased GFR. Pathophysiology is the same one. The portal hypertension is there, this splenic basal dilatation, and there are a lot of neurotransmitters are excreting now, nitrous oxide and the prostaglandins, and they decrease the effective circulatory volume in this fashion. Also because they are all dilated, all vascular system of the abdomen are they dilated, and because of the dilation is sensed by this renin-angiotensin-aldosterone mechanism, and they act on the distal convoluted tubule and to absorb more sodium with water to combat it. But by activation, what happens that the renal sodium avidity will cause ascites on the one hand, and the renal vasoconstriction will occur because of this renin-angiotensin. The renal vasoconstriction will cause hepatorenal syndrome. On the one side, ascites will worsen or ascites will occur. On the other hand, the hepatorenal syndrome will occur. Very beautifully, pathophysiology is described in this slide. Remember this slide. Type 1 is characterized by the rapidly progressive kidney failure without warning, doubling of the serum creatinine to the level greater than 2.5 or halving of the creatinine clearance to less than 20 ml per minute over a period of less than 2 weeks. The warning time is very less. The prognosis of the individual with type 1 is particularly grim, with a mortality rate exceeding more than 50%. After 1 month, patients with type 1 are usually ill, may have low BP, and may require therapy with the drugs to improve the strength of the heart, that is inotropes, or the other drugs to maintain the blood pressure, that is vasopressors. Unlike type 2, in type 1 hepatorenal syndrome, the kidney failure improves with the stabilization. Vasoconstrictors and the volume expanders are the mainstay of treatment. You can interrupt this condition on time. So warning is very, very less. And the type 2 is a progressive, slow, very progressive illness, and is associated with the inciting event. It is defined by the increase of the serum creatinine level to more than 1.5, or creatinine clearance ratio of less than GFR, that is 40 ml per minute, not 20 ml, and a urine sodium is less than 10. It means the urine sodium is absorbing well. It also carries a poor outlook with a medical survival of approximately 6 months unless the affected individual undergoes liver transplantation, not kidney transplantation. Because kidney is only affected by the functional nature of the problems. Type 2 is thought to be a part of the spectrum of the illness associated with the increased pressures in the portal vein circulation. Actually, this occurs because of the portal hypertension. And portal hypertension will lead to the, splenic circulation will be disturbed. The oozing of the fluid, ascites. So it is associated with ascites. Type 1 is not usually associated with ascites, but this condition is always associated with ascites. The spectrum continues with the diuretic resistant ascites, where the kidneys are unable to excrete sufficient sodium to clear the fluid even when the use of the diuretic medication, 1, 2, 3, you use it, but it is a resistant diuretic effect. Most individuals with the type 2 condition, diuretic resistant ascites, before they develop deterioration in the kidney function. They have already actually have got ascites which is refractory to the diuretics. Ultimately they develop this condition, type 2 hepatorenal syndrome. Progressive in nature, creatinine is not much higher, sodium is not much lower, but gradually down and down and down, always associated with the ascites. That is the difference between type 1 and the type 2. The clinical features share three major components: altered liver function, this is important, abnormality in the circulation, hypertension, and the kidney failure. It is always prerenal failure or prerenal erythemia. As these phenomena may not necessarily produce symptoms until late in their course. Individuals with the hepatorenal syndrome are typically diagnosed with the condition on the basis of the altered lab tests. Actually, this condition come into existence when the lab test has been done, which can include the jaundice and altered mental status, evidence of the decreased nutrition and the presence of the ascites. It is related with the cirrhosis. Now, this cirrhosis and these findings indicate that this will occur very soon. Specifically, the production of ascites that is resistant to the use of diuretic medication, which is the characteristic of type 2 renal syndrome, hepatorenal syndrome. Oliguria, which is decrease in the urine volume, may occur as a consequence of the kidney failure. It is actually the malfunctioning of the nephron. However, some individuals with the HRS continue to produce a normal amount of urine, but very less. As these signs and symptoms may not necessarily occur in the syndrome, they are not included in the major and the minor criteria for making a diagnosis of this condition. Instead, this is diagnosed in an individual as a risk for the condition on the basis of the result of the lab test and the exclusion of other causes. Remember, the hepatic renal syndrome occur means that it is end-stage liver disease. You have to go to the liver transplantation. That is the lesson which is. So this is a warning sign that please do something before everything will be gone. Diagnosis will be done. I have already said the essentials of diagnosis previously. The major criteria and the minor criteria. The major criteria include the liver disease with the portal, hypertension, kidney failure, the absence of the shock, but infection, recent treatment with the medication that affect the function of the kidney, nephrotoxins has been given, and fluid losses, the absence of sustained improvement in the kidney function despite treatment with the 1.5 liters of the IV saline, the absence of proteinuria, protein in the urine, there is no protein, and the absence of the kidney disease or obstruction of kidney outflow as seen in the ultrasound and the Doppler. Normal, they are normal, of course, because it is actually the functional disturbance. It is not the organic disturbance. This is the major criteria. The minor criteria are the following: low urine volume, there is oliguria, less than 500 ml in 24 hours, low sodium concentration, hyponatremia, and concentration in the urine, sodium concentration in urine will be low, and there will be a urine osmolality that is greater than that in the blood. It is more than in the blood. Osmolality of the urine, and the absence of the red blood cells in the urine, no hematuria, and a serum sodium concentration of less than 130 associated with the low sodium level in the urine. So where the sodium is gone? Sodium is gone from which side? It is delusional type of the hyponatremia. We can say it is a delusional type of the hyponatremia because the other hormones are acting also, compensating this problem, and this will cause the delusional type of hyponatremia, ADH, and the system I already said about renin, angiotensin, aldosterone, the function action of the aldosterone on the distal cannulate tubule will be actually masked rather. It is not much, or it is hyperactive on the other way. Both can occur. The differential diagnosis of this condition is manifold. I already said that it may be the best, it is the prerenal failure, where you find the hyaline cast in the urine. There will be oliguria and there will be hypernatremia. It is exactly the same thing. As far as the other type of the acute renal failure, that is acute tubular necrosis, involve the damage of the tubules of the kidney, you can prove it by many means. I have already taken class on this. And there will be the post-renal type of a renal failure. It's possible, but it will be excluded by the investigations. It may be the different type of the glomerulonephritis can cause the problem, but it will associate it usually with hematuria and other problems. So this is the differential diagnosis. They are all drug induced. For example, the gentamicin, that is all of these aminoglycosides and the contrast which will cause injury to the nephron. IV administration of the contrast agent used for the medical imaging test, other like MRI or like CT, etc. Management is the one. Other than the general measures that you will do, yes, you will do the general measures. Classified like this: general measures, specific measures, the symptomatic measures, the preventive measures, the surgical measures, the local measures, the dietary measures. आप इसको लिखें और इसके आगे लिखें, कुछ ना कुछ नहीं लिखते हैं तो कुछ बात नहीं, आप डॉट डाल के छोड़ दें, not applied. तो गोल्ड स्टैंडर्ड ये कि you should plan for the liver transplantation because it is the last warning which is given from the liver to you in the form of the hepatorenal syndrome. It is one of the warning signs. Remember this. So this is the message which is given here, rather than, and this is an article which I have taken from it, that this programming of transplantation should be quick, and you should avoid the drugs which are toxic to the kidneys. Any drug which can cause nephrotoxin, so it should be avoided. Or if you want to give according to the creatinine clearance. Otherwise it will damage the kidney. Actually damage the kidney, which is not damaged now. It will damage later on. Remember that you can save the kidneys and liver both by giving the albumin infusion. Salt-free albumin is the best one. And you can raise the blood pressure by vasopressins, dopamine, or non-adrenaline, etc. Radiological shunts to decrease the pressure in the portal vein dialysis and specialized albumin-bound membrane dialysis system. This is called liver dialysis. This is called liver dialysis, not renal dialysis. Molecular adsorbent recirculation system. Special membranes are abutted in the system of the renal dialysis machine. This is called the molecular absorption recirculation system, MARS, and this is called liver dialysis. It is not renal dialysis. It is very, very beneficial to the patient. If it is available in your country, one can prolong the life, and you can plan for the transplantation. The medical therapy you will give here with very cautiously. The mainstay is the acid-base balance, the fluid balance, electrolyte balance, the caloric balance. Other than this, you use the salt-free albumin intravenously, 4 liter or 3 liter can be given. Now here it is written as regime is 1 gram of albumin per kilogram of body weight intravenously on the first day. And it means 80 kilogram person will take 80 gram of the albumin per day, and so on. It will benefit the patient, and it will delay the HRS in this. Another drug which was used by me also, the Hepatorenal. Now, Hepatorenal is an alpha agonist, and second drug we use the octreotide. It is an analog of the somatostatin, a hormone involved in the regulation of the blood vessel tone in the GI tract. So, splenic dilatation can be, inhibited by these drugs. So, the nitrous oxide will not form, and it will not able to dilate the splenic circulation. And the vasopressin analog, one drug is ornithopsin. In a number of studies to be useful in the improvement of kidney function in patients with the hepatorenal syndrome, but it's limited use because of the argument. It is not used very, very commonly, as it can cause the ischemia to the major organs. The teleprasins, a vasopressin analog, largely is rather useful to improving the kidney function in a patient because of the shunting phenomenon, and the blood is diverted to the kidneys more. A trial with the fluorescing Wong demonstrated improved renal function in individuals with type 1 treated with the terlipressin with albumin. This is called the Florence-Wong regime. Both will be used, and they said that this is very beneficial as far as the medical therapy is concerned. The shunt is, transarterial shunt can be done, but it is, major problem is that it will lead to the hepatic encephalopathy. One should avoid this transjugular intrahepatic portosystemic shunt. Should be avoided as much as you can. पर अगर नागुज़ीर है, कोई मजबूरी है, तो वो एक अलग बात है, बगैर हेपेटिक एन्केफेलोपैथी हो जाएगी उसे। इतनी सी बात याद रखिएगा। इसको जो है ना, ज़्यादा बेहतर ये है कि आप इसका गोल्ड स्टैंडर्ड पे जाएं और उसके प्लान करें, मेडिकली इसको मैनेज करें। जो मैंने बताया आपको, सारी चीज़ें आपको बता दी, उससे मैनेज करें ना उसको मैनेज करके जो है ना वो लिवर डायलिसिस करें, जो कि अभी अभी बात की थी हमने कि मॉलिक्यूलर एब्जॉर्बर रिसर्कुलेशन सिस्टम, ये आप डेवलप करें। मशीन होती है इसकी बाकायदा, जैसे कि रीनल डायलिसिस मशीन होती है, इसी तरीके से मार्स मशीन भी होती है, और वो उन्हीं के पास होती है जो रीनल डायलिसिस करते हैं। वो उनको बता दें आप कि क्यों करा रहे हैं आप। तो वो एल्ब्यूमिन बाउंड मेम्ब्रेन होती है, और वो एल्ब्यूमिन को रोकती है बाहर आने से और ब्लड में वापस कर देती है। इसकी अभी जो हाइपोएल्ब्यूमिनेमिया एक बड़ा ख़तरनाक प्रॉब्लम है, क्रॉनिक लिवर डिजीज़ का। वो बहुत वर्स कर देता है, किसी भी कॉम्प्लिकेशन को वर्स करता है हाइपोएल्ब्यूमिनेमिया। तो इसलिए क्या करते हैं कि लिवर डायलिसिस, इसका नाम है बाकायदा, जिसे आपने सुना ही नहीं होगा कभी, तो मॉलिक्यूलर एब्जॉर्बेंस रिसर्कुलेशन सिस्टम। इसको अगर आप पकड़ लें बात को, और ये आप कहें उनसे करने को, तो वो करेंगे। जब कहेंगे तो आप करेंगे ना, उनको बताएंगे क्या मसला क्या है, वाई आर डूइंग दी डायलिसिस। वो तो अपने एक ऑप्शन रखे हुए होते हैं दिमाग में कि भाई पोटाशियम इतना हो, तो क्रेटिनिन कितना हो, तो फला कितना हो, तो फिर डायलिसिस करेंगे। आप उन्हें लिख के दें भाई मसला ये है कि हेपेटोरेनल सिंड्रोम है ये, तो एल्ब्यूमिन बाउंड मेम्ब्रेन चाहिए हमें किसी सूरत से, और फिर डायलिसिस चाहिए, रीनल डायलिसिस नहीं चाहिए, लिवर डायलिसिस चाहिए। तो उनकी बात समझ में आएगी, फिर वो ये करके देंगे, उससे बेनिफिट होगा, पेशेंट की लाइफ प्रोलॉन्ग हो जाएगी। लेकिन बहरहाल कहने का ये कि इन द एंड जो है ना, आप अगर ये कब तक करेंगे, आखिर 1 महीना, 2 महीने, 3 महीने तक प्रोलॉन्ग कर देंगे ज़्यादा से ज़्यादा। लेकिन ऑर्थोट्रोपिक लिवर ट्रांसप्लांटेशन की नीड पड़ेगी, मैचिंग चाहिए, और दिल गुर्दा चाहिए इसके लिए, और बहुत सारी चीज़ें चाहिए इसके लिए, जो हमारे पास जो है ना बहुत कम इदारे हैं जो इसको फॉलो करते हैं। वो डरते हैं, खौफजदा होते हैं। क्योंकि हमारे जो सर्जन्स के साथ प्रॉब्लम ये है कि जो डेथ हो गई उनकी बात नहीं कर रहा मैं, नए सर्जन आए हैं, सिवाय उनके कि जो सर्जरी करते हैं ट्रांसप्लांटेशन की, कुछ अच्छे हैं उनमें से और वो करेज के साथ करते हैं। उनकी शराइत यही है कि 50 साल से ज़्यादा ना हो और उसके साथ कोमॉर्बिड ना हो और ये ना हो वो ना हो। अमेरिकन जो है 70 साल की उम्र में वाले को 80 साल की उम्र वाले को भी कर देते हैं। उन्हें तो लाइफ की चाहिए होती है बंदे की, किसी तरह से ये आदमी किसी तरह ठीक हो और माशरे के अंदर वो सही काम कर सके, उनके काम आ जाए, उनके उम्र का कोई वो नहीं होता। हमारे यहाँ तो उम्र 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 की बात करते हैं। अभी क्या 50 साल के आदमी 10 साल जिंदा रहेगा, इतने पैसे भी लग जाए 40-50 लाख। भाई वहाँ पैसों का मामला नहीं है, ह्यूमन की सर्वाइवल का मसला है, इसको कोई नहीं सोचेगा। लेकिन बहरहाल आप लिख के तो देंगे ना आप कि भाई आप लिवर ट्रांसप्लांटेशन करवाएं। जो लोग करते हैं ट्रांसप्लांटेशन वो आपको मालूम है, मैं नाम बता देता हूँ आपको कि ये जो ट्रांसप्लांटेशन होता है ये आगा खान में भी होता है। ये ट्रांसप्लांटेशन जो होता है नेशनल मेडिकल सेंटर है जो कि एमेजिना रोड पे है, वो भी करते हैं। नूरानी साहब हैं वहाँ पे, बहुत करेजियस सर्जन है, वो भी करते हैं। सूट तो करते ही करते हैं, ऐसा यूटी में होता है, ये शौकत खान अमना मिरेल में भी होता है। और इसी तरह और भी कुछ इदारे हैं पाकिस्तान में, वो भी ये करते हैं ट्रांसप्लांटेशन, लिवर ट्रांसप्लांटेशन। अगरचे उनकी जो मोर्टेलिटी रेट ज़्यादा है, ठीक है, आप कोशिश तो कर सकते हैं ना, हो सकता है कि वो कामयाब हो जाए आप। कि मैंने 1-2 मरीज़ देखे, इनके 7-5 साल हो गए हैं अभी तक, वो ठीक है बिल्कुल। वह लिवर ट्रांसप्लांटेशन इसलिए किया गया था कि उनको पकड़ लिया गया और वो रीनल सिंड्रोम में, हेपेटिक रीनल सिंड्रोम उनको अभी स्टार्ट ही हुआ था कि उन्होंने इसको फ़ौरन प्लान करके इसको कर दिया। सबसे अच्छी बात ये कि उन्होंने आगे जाने ही नहीं दिया ना। तो अब जो है ना वो पेशेंट अभी भी सर्वाइवल पे हैं, अगरचे वो इम्यूनोसप्रेशन लेते हैं लेकिन वो अभी भी ठीक ठाक है। तो इसलिए हमारा ख्याल है कि इसको जो है वो हमें इसे वो कर लेना चाहिए, एग्री कर लेना चाहिए इस चीज़ के साथ। मैंने इस पर बड़ा लंबा डिस्कशन दे दिया, हालांकि इसके ऊपर 6 लाइनें लिखी हुई हैं, 8 लाइनें लिखी हुई मिलेंगी आपको। मैंने इसको एलेबोरेट करके इसकी टाइप्स, क्लासिफिकेशन क्या है जो समझ में आ सकती है हमारे, वो मैंने आपको बता दिया है। तो इसीलिए मैं ये कहता हूँ कि आप जो है ना इसको देखें, आप प्रिवेंट करें आप इस कंडीशन को। कोई भी जब भी आदमी को आप डायग्नोज करें सिरोसिस को, तो ध्यान में रखें कि इसको कभी ना कभी हेपेटोरेनल सिंड्रोम हो जाएगा। उसको बचाने के लिए आप इन्फेक्शन नहीं होने दें, उसको रोकें किसी तरह से, हेमरेज को, यानी ज़ाहिर है कि जो वेराइसिस है उसको आप मैनेज करने की कोशिश करें। और उसके बाद जो है वो पोर्टल हाइपरटेंशन को मैनेज कर रखें, कम से कम रखें। फिर जो है ना वो वीकली या रख लें, उसके लिए इंतजाम रखें कि भाई इसको पैरासिंथेसिस करना है और उसको रिप्लेस करना है एल्ब्यूमिन के साथ, सॉल्ट फ्री एल्ब्यूमिन के साथ। ये सारी चीज़ें आप करेंगे। और स्पॉन्टेनियस बैक्टीरियल पेरिटोनाइटिस कंडीशन याद रखिएगा, जब किसी को हो जाती है तो चांसेस जो होते हैं वो HRS होने के बढ़ जाते हैं। इससे पहले कि ये कुछ गड़बड़ करे, आप पहले से जो एंटीबायोटिक दे के इसको सप्रेस करें, इसको ख़त्म करने की कोशिश करें। इस तरह से ये प्रिवेंशन होता है। इसके लिए वैक्सीन आप इस्तेमाल नहीं कर सकते, कोई चीज़ इस्तेमाल नहीं कर सकते, लेकिन आपको जितनी चीज़ें पहले बताई गई हैं ना, आपसे पहले मैंने 5 लेक्चर ले चुका हूँ, वो सारी की सारी इम्प्लीमेंट कर दें यहाँ पे, तो फिर ये HRS होने का चांस कम हो जाएगा। होगा तो ज़रूर, लेकिन इतना जो है ना वो बहुत, यानी जिसे कहते हैं उसकी पोटेंसी इतनी ज़्यादा नहीं होगी कि वो आपके लिए प्रॉब्लमेटिकल हो जाए। इतना बात याद रखिए कि हेपेटोरेनल सिंड्रोम अलग चीज़ है और किडनी डैमेज अलग चीज़ है, दोनों को बिल्कुल अलग अलग रखिएगा ध्यान में। तो फिर ये बात आपकी समझ में आ जाएगी आसानी के साथ। आई होप कि ये बात आपकी समझ में आ गई होगी। वमा अलैना इल्लल बलाग, और विल टॉक लेटर ऑन आफ्टरवर्ड्स। अस्सलाम वालेकुम व रहमतुल्लाहि व बरकातहू।